Hello and welcome everybody. I am Dr. Rupali at present working as Associate Professor, Department of Critical Care Medicine, IMS Hospital, Bhubaneswar. Today I will be presenting the topic on hyponatremia. Coming to epidemiology, it is defined when plasma sodium concentration is less than 135 millimoles per liter, which is one of the most common molecular disorder encountered. Approximately 3% of the hospitalized patients and 30% of the ICU patients are being affected by this disorder. The contributing in-hospital mortality is almost 30 to 40%. Morbidity and mortality depends on magnitude and rate of development of hyponatremia. Patient's age, gender, nature, and severity of the underlying disease also accountable for this. Classification of hyponatremia. Definition of hyponatremia based on biochemical severity. It is defined as mild hyponatremia when it ranges from 130 to 135. Moderate hyponatremia in 125 to 129 millimoles per liter, and defined as profound hyponatremia when the serum sodium concentration is less than 125 millimoles per liter. Also, it is based on time of development. Hyponatremia is defined as acute and chronic. Acute hyponatremia when it is present less than 48 hours, and chronic if it is present more than 48 hours. Definition of hyponatremia based on symptoms. To define moderately symptomatic hyponatremia is moderately severe symptoms of hyponatremia present and severely symptomatic if severe symptoms are present. These are the symptoms documented. Moderately severe with nausea, with vomiting, confusion, headache. In severe, there is vomiting, cardiorespiratory distress, abnormal deep pulmonary seizure, even coma also been documented. Coming to pathophysiology, hyponatremia will coexist with normal, high or low plasma osmolality. The diagnostic algorithm for hyponatremia always begin with assessment of plasma osmolality. Estimated plasma osmolality is 2 multiplied by plasma sodium plus glucose divided by 18 plus BUN, that is blood urea nitrogen, divided by 2.8 all in milligrams per dl. Plasma osmolality should be measured directly if there is any suspicion of unmeasured osmotically active solutes like mannitol or glycerol is there. Coming to the diagnostic algorithm for hyponatremia. If plasma sodium is less than 135, it is defined as hyponatremia. Then we have to measure the plasma osmolality. If it is 280 to 295 within that range, then it is pseudo hyponatremia or 50 days hyponatremia or isotonic hyponatremia. If plasma osmolality is more than 295, it is hypotonic hyponatremia. If plasma osmolality is less than 280 millimoles per liter, then it is hypotonic hyponatremia. Then these are the various diagnostic algorithms which is for hypotonic hyponatremia. I'll discuss each of these aspects individually. Coming to the isotonic hyponatremia, which is otherwise called as fictitious or pseudo hyponatremia. The laboratory artifact seen with the analytic technique that measured mass of sodium per unit volume of the plasma sample marked hypertriglyceridemia or hyperproteinemia like paraproteinemia. When methods involve pre-dilution step, then it leads to the measuring error which lead to hyponatremia, or it is called as isotonic hyponatremia or pseudo hyponatremia. If direct potentiometry is used, then it avoids this problem. Then comes the hypertonic hyponatremia, where plasma osmolality is more than 295 millimoles per liter. Presence of extracellular fluid of abnormal amount of osmotically active solutes other than sodium, like glucose, mannitol, or glycerol. If any of these substances are present, then it leads to increase in plasma osmolality. Osmotic pressure exerted by non-sodium solute lead to redistribution of water from intracellular fluid to extracellular fluid compartment. This results in intracellular dehydration and hyponatremia. Obviously, when fluid is distributed from intracellular to extracellular fluid, it leads to dilution of the sodium, thereby hyponatremia. Hyponatremia here is real in hypertonic hyponatremia, but it is accompanied by hypertonicity and decrease in cellular volume, intracellular volume, as fluid is shifted from intracellular to extracellular compartment because of these hyperoncotic compounds. Then comes hypotonic hyponatremia, where serum osmolality is less than 280 millimoles per liter. It is caused by inability of kidney to excrete sufficient electrolyte-free water to match water intake, either because the normal diluting capacity of the kidney is overwhelmed by excessive water intake or because the diluting capacity is impaired. Either it is overrun because of excess water intake or it is impaired because of the defect. These alternatives can be measured using the urine osmolality. Coming to hypotonic hyponatremia, where the urine osmolality is less than 100 milliosmoles per kg. One of the causes is primary polydipsia. Urine osmolality less than 100 milliosmoles per kg in hypotonic hyponatremia. There, excessive water intake is one of the cause. One can ingest and excrete about 20 liters of water a day without affecting plasma osmolality appreciably. So, what is primary polydipsia or psychogenic polydipsia? It is commonly associated with OCD, obsessive compulsive disorder, or psychotic patients. Along with they have concurrent urinary diluting defects. These defects could be due to underlying mental illness or side effect of psychotropic or anticonvulsant medications. Another cause of hypotonic hyponatremia with low urine osmolality, less than 100 milliosmoles per kg, is low solute intake. One is primary polydipsia, other is low solute intake. What are the causes? The causes are like beerpotomania or very low daily solute intake, like strict vegetarians and nutritionally depleted diets. Beer is very low in protein and salt contents, only 1 to 2 millimoles per solute. Inadequate dietary intake of solutes leads to reduced urinary solute excretion. Yes, there is reduction in urinary solute excretion. This leads to limitation of the water excretion. So hyponatremia ensues even with relatively moderate polydipsia. Here the urine sodium concentration is very low, less than 10 to 20 millimoles. After hypotonic hyponatremia with low urine osmolality, then another cause, urine osmolality more than 100 milliosmoles per kg. The urine osmolality more than 100 milliosmoles per kg, it is associated if there is impaired urinary diluting capacity. The concentrated urine reflects high circulating ABP level, that is vasopressin. Circulating ABP is affected by systemic hemodynamics and osmolality. So, assessment of extracellular fluid volume status in hemodynamics is crucial. Hypotonic hyponatremia may be associated with normal, decreased, or increased extracellular fluid volume. The hypotonic hyponatremia with normal extracellular fluid volume is euvolemic hyponatremia. Patients with pure water excess appear clinically euvolemic as excess water distributes through total body water. 1/3 of the total body water is extracellular and only 1/12 is intravascular. So, only evidence of slight intravascular volume expansion is low blood urea nitrogen and plasma uric acid level. Euvolemic hyponatremia, which is one of the components of hypotonic hyponatremia with concentrated urine, that is urine osmolality more than 100 milliosmoles per kg. Then the classical is CR, syndrome of inappropriate ADH secretion. Here, elevating circulating AGH is inappropriate. Why it is called CR? Because the elevated circulating ADH is inappropriate to important physiologic stimuli for ABP or vasopressin stimulator. What are they? They are the osmotic or hemodynamic. This ADH secretion is independent of this hemodynamic or physiologic stimulus. In the CR, there is extent of water ingestion exceeds water elimination by the insensible GI or renal routes, leading to hypotonic hyponatremia. Because normal response to extracellular hypotonicity is elaboration of maximum dilute urine always. If there is hypotonicity, then it leads to elevation of the ADH secretion, this leads to maximum dilute urine. Urine need only be inappropriately concentrated, more than 100, to diagnose CR. Hypothyroidism and glucocorticoid insufficiency may impair urinary dilution. So, patients in whom diagnosis of CR is entertained should undergo appropriate test of thyroid and adrenocortical function. Coming to the diagnostic criteria for syndrome of inappropriate ADH secretion, Essential criteria is effective serum osmolality less than 275 milliosmoles per kg. Then obviously, it is hypotonic hyponatremia, and urine osmolality more than 100 milliosmoles per kg at some level or at some level of decreased effective osmolality. Clinical patients are euvolemic. Urine sodium concentration is more 30 millimoles per liter in normal dietary salt and water intake, and there is absence of adrenal, thyroid, or pituitary renal insufficiency. The supplementary criteria has many more, like uric acid is low, less than 4 milligram per liter. Serum urea is also low, and failure to correct hyponatremia after saline infusion, and many more criteria as well. Coming to the causes of syndrome of the inappropriate ADS, basically 5 different types are the causes: malignant diseases, pulmonary disorders, diseases of central nervous system, drugs, and other causes. It has been divided like this. Malignant disease like lungs, small cell carcinoma of the lung is one of the most common reason for syndrome of inappropriate ADS secretion. In CNS diseases, the infection, meningitis, encephalitis, brain abscess, all this can lead to syndrome of inappropriate ADS secretion. Then there are 4 patterns of syndrome of inappropriate ADS secretion. 1/3 of patients there is unregulated erratic AVP secretion. There is no correlation between serum osmolality and circulating AVP level. Others fail to suppress AVP secretion at lower serum osmolality with a normal response curve to hyperosmolar conditions. Others have reset osmostat with a lower threshold osmolality and left shift of osmotic response curve. There, vasopressin levels are regulated normally by tonicity but around the lower set point of normal. The fourth subset, there is no detectable circulating AVP, suggesting either a gain in function in renal artery absorption or circulating antidiuretic substance that is distinct from AVP. The gain in function mutation of a single specific residue in V2 AVP receptor constitute the activation of receptor in absence of AVP. This led to nephrogenic CR. There is, in absence of vasopressin, there is constitutive activation of the receptor. In fact, CR patients are not euvolemic but clinically volume expanded due to AVP-induced water and sodium chloride treatments. Serum uric acid is low in CR. It is suppressed proximal due to suppressed toxicity transport in settings of increased distal tubular sodium chloride and water transport. In contrast, in hypovolemic hyponatremic patients are hypovolemic. The another cause of euvolemic hyponatremia, apart from CR, is the athletes, where the hyponatremia less than 135 is seen in almost 15% of marathon and triathlon athletes, and 0.6% runners can develop severe hyponatremia, less than 120 milligram per liter. The major risk factors associated with them are BMI less than 20, racing time extends more than 4 hours, or there is excessive fluid intake during the race. After euvolemic hyponatremia, which is one of the subset of the hypotonic hyponatremia, the next subset comes, which is the hypovolemic hyponatremia. Hypovolemia, there is marked neurohormonal activation. This leads to increased circulating vasopressin or ADH. This ABP, ADH helps to preserve blood pressure by vascular baroreceptor, mediated P1A receptors, and water reabsorption via renal B2 receptors. The activation of the B2 receptors leads to hyponatremia in setting of increased free water intake. This is the pathophysiology of hypovolemic hyponatremia. The hypovolemic hyponatremia can be non-renal causes. The various non-renal causes are GI loss, vomiting, diarrhea, tube drainage, insensible loss like sweating form, or sodium chloride in water lost in absence of adequate oral replacement. Urine sodium concentration is typically less than 20 millimoles in case of hypovolemic hyponatremia due to non-renal cause. Urine sodium concentration less than 20 millimole in absence of cause of hypervolemic hyponatremia predicts rapid increase in plasma sodium in response to IV normal saline. Here therapy is the IV normal saline. The saline therapy thus induces water diuresis in this setting to correction of hyponatremia. The hypovolemic hyponatremia is renal causes. Now the renal causes inappropriate loss of sodium chloride in urine, leading to volume depletion and increase in circulating AVP. Urine sodium concentration here is high. more than 20 millimoles. Some nephropathies leading to hyponatremia when sodium intake is reduced due to impaired renal tubular function. Causes are reflux nephropathy, interstitial nephropathies, post-obstructive neuropathy, medullary cystic disease, recovery phase of edema. Other renal causes of hypotonic hyponatremia contribute to diuretics. The thiazide diuretics cause hyponatremia by a number of mechanisms, polydipsia and diuretic-induced volume depletion. Thiazides do not inhibit renal concentrated mechanism, so that circulating AVP retains its full effect on renal mechanism. There is loop diuretics, which is less frequently associated with hyponatremia than thiazides. They inhibit Na plus K plus 2 chloride minus channel in the thick ascending limb of glucophylline, which blunts the countercurrent mechanism, then reducing the ability to concentrating ability of the kidney. Increases excretion of any osmotically active non-reabsorbable substance can lead to volume depletion and hyponatremia. Causes are glycosuria or ketonuria in cases of starvation, diabetic or alcoholic ketoacidosis, or bicarbonate in RPA, metabolic alcoholism, where associated bicarbonate leads to loss of sodium. These are the other renal causes. Hypovolemic hyponatremia, one of the most important causes is CSW, cerebral salt wasting. The hyponatremia with clinical hypovolemia and inappropriate natriuresis is the hallmark of this disorder. It is associated with various intracranial diseases like subarachnoid hemorrhage, traumatic brain injury, craniotomy, encephalitis, meningitis, and all. Key features that distinguish CSW from CR is the volume depletion. The CSW patients are hypovolemic. The volume depletion and urinary sodium excretion is inappropriate to patient volume status in CSW. Distinction from CR is critical as CSW respond to aggressive sodium chloride depletion. After hypovolemic hyponatremia, then comes the hypervolemic hyponatremia. Pathophysiology. These happen in sodium-avid edematous disorders like congestive heart failure, cirrhosis, nephrotic syndrome. The pathophysiology is similar to hypovolemic hyponatremia, except that decreased arterial filling and circulating integrity due to specific etiologies. In the hypovolemic hyponatremia, there is obvious hypovolemia, but here there is effective arterial underfilling, which is decreased due to the disease process, like cardiac dysfunction in CHF or peripheral vasodilation, all this in cirrhosis. This effective arterial underfilling leads to activation of the ADH vasopressin receptor and circulating ABP is escalated. Increase in total body sodium chloride is accompanied by proportionally greater increase in total body water. Here also increase in body sodium, but the total body water increase is much more than increase in sodium. This leads to reduction in plasma sodium concentration. The causative disorders can be separated by urine sodium concentration. If it is due to acute and chronic renal failure, this leads to increase in urine sodium concentration. In sodium iodide state may be obscured by diuretic therapy also in these disorders. Disorders of hyponatremia, degree of hyponatremia in these patients similar with index of associated neurohormonal activation and important prognostic indicator. Coming to the hypotonic hyponatremia, the reassessment of the causes which we have discussed. The hypotonic hyponatremia is divided into three varieties based on the assessment of volume status: the hypovolemia, euvolemia, and hypervolemia. In hypovolemia, there is decrease in total body water and total body sodium also. If urinary sodium is more than 20, it is due to renal causes, as I have discussed before. If urinary sodium is less than 20 millimoles, it is due to extrarenal and GI causes. And euvolemic hyponatremia, there is no edema, total body water is increased, sodium is almost normal, but if it is urinary sodium is more than 20, the causes are syndrome of inappropriate ADH secretion and hypothyroidism and glucocorticoid deficiency. Hypervolemia. Hypervolemia, the total body water is increased, total body sodium is increased, but total body water increase is out of proportion to sodium increase. This leads to dilution and hyponatremia. If urine sodium is more than 20, then it is acute and chronic renal failure is the cause. If it is less than 20, then other causes like congestive heart failure, cirrhosis, and nephrotic syndrome come into picture. Coming to clinical features, hyponatremia induces generalized cellular swelling, consequence of water movement down osmotic gradient from hypotonic PCF to intracellular fluid. Symptoms are mainly neurologic and cerebral edema within a rigid skull. Initial CNS response to acute hyponatremia is increase in interstitial pressure. This leads to sunking of extracellular fluid and solutes from interstitial space into CSF, then into systemic circulation. The initial response is increase in interstitial pressure. When interstitial pressure is increased, this leads to sunking of the extracellular fluid and solutes from the interstitial space into CSF, then into systemic circulation. This is also accompanied by influx of major intracellular ions from the brain cells. If there is increase in interstitial pressure, these major ions are influxed from intracellular compartment, that is from the brain cells, so that the more fluid is not dragged into the intracellular compartment. Obviously, these are the electrolytes which drag water, that is solvent, from its higher to lower concentration. When these electrolytes are influxed from the cells, then less water is being absorbed into the cell. This leads to less cellular swelling. This is the first initial response or protection from the adverse effects of the hyponatremia. Coming to acute hyponatremic symptoms, the acute hyponatremic encephalopathy ensues when these volume regulatory mechanisms are overwhelmed. After some time, these mechanisms are overwhelmed. There were rapid decrease in tonicity, resulting in acute cerebral edema, obviously. The early symptoms in nausea, headache, vomiting, severe complications like seizure, brainstem herniation, coma, and even death has been documented. The key complications of acute hyponatremia, normocapnic or hypercapnic respiratory failure, associated hypoxia may imply neurologic injury. This is basically due to non-cardiogenic or neurogenic pulmonary edema. The various causes of acute hyponatremia can be iatrogenic, post-operative patients like postmenopausal women, during hysteroscopy, during TURP surgery, during uterine surgery, when there is hypotonic fluids are used, colonoscopic preparation, or there is recent institution of thiazide diabetes, polydipsia, drug-induced, exercise-induced. These are all multifactorial causes. These are the causes of acute hyponatremia. Acute symptomatic hyponatremia is obviously a medical emergency. Coming to chronic hyponatremia, the symptoms. Chronic hyponatremia results in efflux of organic osmolytes from brain cells. This response reduces intracellular osmolality and the osmotic gradient, favoring water entry, which I have discussed before. This reduction in intracellular osmolality is largely complete within 48 hours. This is the time period which clinically defines the chronic hyponatremia. Thus, the cellular response to chronic hyponatremia does not fully protect patients from symptoms, usually at plasma sodium 125 millimoles. The patients are judged asymptomatic, but they can manifest subtle gait cognitive defects that reverse with correction of hyponatremia. Chronic asymptomatic hyponatremia increases the risk of falls and kidney fractures. Hyponatremia also reduces bone density. Management of chronic hyponatremia is complicated by asymmetry of cellular response to correction of plasma sodium. Specifically, the reaccumulation of organic osmolytes by brain cells is attenuated and delayed, which osmolarity increases after correction of hyponatremia. So, this leads to degenerative loss of oligodendrocytes and development of osmotic demyelination syndrome. Overly rapid correction, more than 8 to 10 millimoles in 24 hours or 18 millimole in 48 hours, this leads to osmotic demyelination due to disruption and integrity of blood-brain barrier, which allows entry of immune mediators and contribute to demyelination. ODS classically affect the pons, which is previously called as central compound monolysis, wherein delay in reaccumulation of osmolytes are pronounced. That's why it affects the pons. Presents one or more days after overcorrection, paraparesis, quadriparesis, dysphagia, dysphagia, diplopia, locked-in syndrome, and loss of consciousness is documented. This is mainly the symptoms related to pons involvement. but there is can be extra pontine myelinolysis, that is occur in cerebellum, lateral geniculate body, thalamus, putamen, cerebral cortex, and subcortex. That's why previously it was called as central pontine myelinosis. Now, due to extra pontine involvement, change the term is changed. Now it is called osmotic demyelination symptoms. The clinical presentation vary as a function of extent and localization of the extra pontine myelinolysis. Ataxia, mutism, Parkinsonism, dystonia, catatonia is reported. Re-lowering of the plasma sodium concentration after severely rapid correction can prevent or attenuate ODS also. Even appropriately slow correction can be associated with ODS. The risk factors can be alcoholism, chronic malnutrition, hypokalemia, or liver transplantation. Coming to the diagnostic evaluation of the clinical features, we should focus on the diagnostic evaluation. Clinical assessment should focus on underlying cause, detailed drug history, clinical assessment of volume status, evaluation of possible causes of excessive saturating ABV like volume status, drug, nausea, pain, all these. Radiology, like imaging, pulmonary or CNS gauge for diagnosis, CT thorax, small cell carcinoma of the lung in patients with smoking history. Measurement of serum osmolality is important to exclude the causes of hyponatremia. Elevated BUN and creatinine reflect renal dysfunction, adrenal insufficiency, or hypoaldosteronism. There is associated increase in plasma potassium concentration. Serum glucose should also be measured. Plasma sodium falls by 1.6 to 2.4 millimoles for every 100 milligram per deciliter, increase in glucose concentration. So, due to glucose-induced water reflux from the cell, which results after correction of hyperglycemia. So, these parameters measurement is very much important diagnostic evaluation of the hyponatremia. Measurement of serum uric acid should always be performed, which I have discussed before. In syndrome of inappropriate ADS, uric acid level is less than 4 mg per kg, but in volume depleted state, it is hyperuricemia. Appropriate clinical settings like thyroid, adrenal, and pituitary function should be tested. Which hypothyroidism or secondary adrenal failure related to pituitary insufficiency, which is important causes of euvolemic hyponatremia. The primary adrenal failure is hypovolemic hyponatremia. So do post-intermittent stimulation test. Urine electrolytes and osmolality is very much important test. Urine sodium less than 20. 30 consistent with hypovolemic hyponatremia in absence of hypervolemic sodium epistate. CR increase urine sodium more than 30 millimoles. Substantial overlap in urine sodium concentration produces patients with CR and hypovolemic hyponatremia. So ultimate gold standard for diagnosis of hypovolemic hyponatremia is plasma sodium corrects after hydration with normal saline. With thiazide-associated hyponatremia present with higher than expected urine sodium, one should defer making diagnosis of CR until 1 to 2 weeks after discontinuing thiazide. There is associated thiazide intervention. Urine osmolality is less than 100 millimoles, suggestive of polydysphagia. All I have discussed, urine osmolality more than 400 indicate ABP excess being dominant. The intermediate values are consistent with multifactorial pathophysiology. As one patient can have multiple associated problems. The decreased solute intake typically like beopocomania or solute intake is less, urine sodium is less than 20 millimoles, and urine osmolality in the range of less than 100. Coming to the management part. Management part, this algorithm is based on the hyponatremia guideline, which is very important guideline. The ways symptoms wise it is being divided. It is severe symptoms, present or absent, or moderately severe symptoms. Then first I discuss the hyponatremic severe symptom. If it is present, what we should do? If there is no severe symptom, what to do? Hyponatremic severe symptoms. The first are management, regardless of hyponatremia is chronic or acute, hyponatremia is severe symptoms. We recommend prompt IV infusion of 150 ml 3% hypertonic saline over 20-minute infusion, which suggests checking serum sodium concentration after 20 minutes by repeating the infusion of 150 ml 3% NS for the next 20 minutes. That is, we have to give 150 ml 3% NS as a bolus, then checking serum sodium after 20 minutes, preparing for the next infusion. 2 times we can do. We suggest repeating therapeutic recommendations twice or until a target 5 millimoles per liter increase has been achieved. Manage patients with severe symptoms in an environment where close biochemical monitoring is feasible. Follow-up management in case of improvement of symptoms after increase in 5 millimoles per liter in serum sodium concentration in the first hour, regardless it is acute or chronic. That is after at least 2 times followers or 5 millimoles increase. We recommend stopping the infusion of hypotonic saline. If there is improvement of symptoms, keeping the IV line open by infusing smallest feasible volume of 0.9% saline until the cause specific treatment is started. Diagnosis specific treatment if available based on the diagnosis, the diagnostic algorithm and all that. Recommendations are limiting the increase in serum sodium concentration to total of 10 millimoles per liter during the first 24 hours and additional 8 millimoles during every 24 hours thereafter until serum sodium concentration is less than or until serum sodium reaches the 130 millimoles per liter. Suggest checking the serum sodium concentration after 6 to 12 hours and daily afterwards until the serum sodium concentration is being stabilized. Hyponatremia with severe symptoms. This is follow-up management in case of no improvement of symptoms after increase in serum sodium concentration in the first hour by 5 millimole, regardless of the hyponatremia is acute or chronic. That is, first I have discussed what to do if there is improvement, what to do. But here it is hyponatremia with severe symptoms, which is not being improved even after correction. There it is recommended to continue IV infusion of 3% hypotonic saline, equivalent aiming for an additional 1 millimole per liter per hour increase in serum sodium concentration, and stopping the infusion of 3% saline or equivalent when symptoms improve. The serum sodium concentration increase 10 millimoles in total of serum sodium concentration reaches 130, then should stop the infusion. Either 130 or there is 10 millimole increase within 24 hours. Then along with that should proceed for additional diagnostic investigations. Coming to hyponatremia with moderately severe symptoms. After severe symptoms, moderately severe symptoms, recommend starting from diagnostic assessment algorithm, medications or other factors that can contribute to or provoke hyponatremia. They suggest immediate treatment with single IV infusion 150 ml 3% NS over 20 minutes and aiming at similarly 5 millimoles per liter for 24-hour increase, and suggest limiting the increase in sodium concentration to 10 millimole over the 24 hours or 8 millimole during every 24 hours thereafter till it reaches 130. And suggestions are checking the serum sodium concentration after 1 hour, 6 hours and 12 hours. You have to rapidly or repetitively check the serum sodium concentration. After elevation of severe symptoms, the corrective guideline for chronic hyponatremia appropriate should be taken into account with hypotonic saline, which is sodium concentration of 530 or non-NS 154 millimoles. Traditional approach is to calculate sodium deficit, which is 0.6 multiplied by kg body weight multiplied by target sodium minus the starting plasma sodium. We have to calculate the sodium deficit, then the calculation of the rate is for the desired. If we are not planning to escalate 10 millimoles over the 24 hours. Increase in plasma sodium concentration highly unpredictable during treatment of hypotonic saline. So, frequent monitoring. The plasma sodium concentration should be monitored every 4 hours, 2 to 4 hours. Patients with chronic hyponatremia at risk of osmotic demyelination syndrome is plasma sodium corrected by 8 to 10 millimoles within first 24 hours and by 18 millimoles within first 48 hours. Response to interventions like hypotonic saline, isotonic saline or ATP antagonists can be highly unpredictable. So frequent monitoring is most important during corrective therapy. After correcting plasma sodium, focus should be treatment or withdrawal of the underlying cause. Hypovolemic hyponatremia due to CHS, then treatment of cardiomyopathy is mainly responsible for it. Protomania, low solute intake, respond to rapidly IV saline and resumption of the normal diet. Patient with protomania are high risk of developing ODS due to associated hypokalemia, alcoholism, malnutrition, and high risk of overcorrected plasma sodium. Water deprivation has long been cornerstone therapy for chronic hyponatremia. Patients who are excreting minimum and electrolyte-free water will require aggressive fluid restriction. Urine to plasma electrolyte ratio, like urine sodium plus potassium divided by plasma sodium, is a quick indicator of electrolyte-free water excretion. Patient with ratio more than 1, there should be aggressively restricted fluid 500 ml per day. Ratio of 1 should be restricted to 500 to 700 ml per day, and those with ratio less than 1 should be restricted to 1 liter per day. This is basically from Harrison's textbook of internal medicine, this data. With hypokalemic potassium replacement will solve to increase plasma sodium concentration. Plasma sodium concentration is a function of both exchangeable sodium and potassium divided by total body water. So aggressive replacement of potassium is potential to correct the plasma sodium deficit. Plasma sodium respond to increase in dietary solute intake, which increases ability to excrete free water. Patients who therapy with fluid restriction, potassium replacement, increase in solute intake phase may merit pharmacological therapy. Many patients with CR respond to combined therapy with oral furosemide and oral salt tablet. Furosemide inhibit renal countercurrent mechanism and blunt urinary concentrating ability, and salt tablets counteract the diuretic associated natriuresis. Demeclocycline is a potent inhibitor of the principal cell used in patients whose sodium level do not increase in response to furosemide and salt. This agent can be associated with reduction in GFR due to excessive natriuresis and dietary-renal toxicity. So, should not be used frequently. If available, palatable preparation of oral urea can be used to manage CR. Basically, these treatments are for CR and hypervolemic hyponatremia, never for hypovolemic hyponatremia. Increase in solute excretion with oral urea injection increases free water excretion, which reduces the plasma sodium. ABP antagonists, Vaptans, are highly effective in CR and hypervolemic hyponatremia due to heart failure or cirrhosis. It increases plasma sodium due to their aquaretic effects, which augments the free water clearance. Tolvaptan is currently only oral V2 receptor antagonist approved by US FDA. The dose usually is 15 mg over 24 hours, that is once daily. Conivaptan is the only available IV Vaptan. Mixed V1A V2 antagonist effect. There is moderate risk of hypotension, obviously, due to V1A antagonistic effect. Therapy with Vaptans must be initiated in a hospital setting with a liberalization of fluid restriction. Fluid intake should be more 2 liters per day, and there should be close monitoring of the plasma sodium concentration. Although approved for management of all but hypovolemic hyponatremia and acute hyponatremia, the clinical indications are limited. That is, Vaptan should never ever be used for hypovolemic hyponatremia or patients with acute hyponatremia. The oral tolvaptan is most appropriate for CR, patients with small cell lung carcinoma that has not responded to water restriction or diuretic therapy and salt. Abnormalities LFT has been reported with chronic Vaptan therapy. The use of this agent should be restricted to less than 1 to 2 months only. The administration of supplemental oxygen ventilator support in critical environment is very much important in patients with acute hyponatremia. In the event that patients develop acute pulmonary edema, hypercapnic respiratory failure, the plasma sodium, if there is overcorrection following any therapy, either hypotonic saline, isotonic saline, or Vaptans, the hyponatremia can be safely re-induced or stabilized by administration of ABP antagonist, ABP agonist, desmopressin, or administration of free water, typically 5% dextrose. The goal is to prevent or reverse the development of osmotic deficiency syndrome.